George Adams, interventional cardiologist at Rex Hospital, part of the University of North Carolina at Chapel Hill Health System. Today we're going to be discussing the TOBA II below-the-knee 6-month pivotal data. Critical limb ischemia currently afflicts about 2 to 3.5 million people in the United States annually. The forecast is to exceed 4 million by the year 2030. Critical limb ischemia typically is multi-level. Currently, below the knee, plain old balloon angioplasty is the standard therapy. Historically, these have had suboptimal results when using plain old balloon angioplasty. In fact, there's about a 31% dissection rate. A lot of these dissections go unrecognized because of medial calcium, bone interference, or small reference vessel diameter. These dissections are a predictor of infrapopliteal restenosis. Currently, there are no approved implants for below the knee in the United States. I'd like to introduce the TAC in the vascular system. These are 6mm nitinol scaffolds. There's 4 preloaded within each shaft. They can treat a reference vessel diameter from 1.5 to 4.5 millimeters. It's an over-the-wire delivery system, 4 French going over an 0.14-inch wire. There's currently a wealth of data, especially above the knee. In fact, there's been 3 trials showing great safety and efficacy. Today we're going to discuss the 6-month pivotal data for TOBA II below the knee. The study design, this is impressive. This is a trial that included 100% dissected vessels. The primary endpoints included safety, which was major adverse limb events, plus post-operative death at 30 days, as well as the efficacy of freedom from major adverse limb events at 6 months and post-operative death at 30 days. I'd like to give thanks to the current TOBA II below-the-knee investigators, as you can see here. The TOBA II below-the-knee key eligibility criteria, well, these were P2 segment to tibial vessels that were enrolled. To be enrolled, you had to have less than 30% post-PTA residual, and all of these had dissections. The baseline patient characteristics or demographics, as you can see, the majority were Rutherford 4 to 5. Current or former smokers comprised about 62%. Diabetics were about 66%. Chronic renal insufficient patients, 24%. The reference vessel diameter in that treated by plain old balloon angioplasty ranged between 2.6 and 3.5. The chronic total occlusions comprised about 48% of the population, and the PTA length on average was 154 millimeters. As you can see here, all 3 vessel beds were treated, proximal to distal. In fact, as you can see, there was a significant group that were treated in the lower 1/3 of the leg. Device success was 97%. The bailout stent rate was low at 1.3% and even lower within the TAC segment at 0.4%. The classification of these dissections, as you can see, the majority were class A or B. So it may make us think twice about whether we should treat a non-flow limiting dissection. All of these dissections were fully resolved with the TAC placement, as you can see here to the right of the slide. The number of dissections per patient on average was 1.4. The dissection length on average was 24 millimeters, and the TACs per patient were 4. Remembering that 4 TACs are included within each sleeve. If we look at the actual results, each one of the primary endpoints were met. If you look at the primary safety endpoint, a male plus pod at 30 days, it was 1.3%. And the primary efficacy, which again was freedom from major adverse limb events at 6 months, plus perioperative death at 30 days, was 95.6% in the intention to treat and 95.8% in per protocol. The actual 6-month Kaplan-Meier TAC segment and lesion patency were impressive at 87.7% for segment patency and 87.3% for lesion patency. Additionally, limb salvage and freedom from CTLR was the target limb salvage was 98.6% and 92% for the clinically driven target lesion reintervention. All-cause mortality and amputation-free survival, again, were high at 97% for survival and amputation-free survival at 95.7%. In terms of wound healing, about 57% of these wounds were healed at 6 months. there were another 16% that were improving along this 6-month time period, totaling a gross amount of 73.8% of wounds were healed or improving at 6 months. If we look at Rutherford class, the majority of them started at 5 at about 50%. As the 6-month continued, I think everyone can appreciate, the majority moved to the Rutherford classification 0 to 1 at about 56%. In terms of hemodynamics, the toe brachial indices over the 6-month period improved significantly from baseline. If we look at the quality of life metrics, they also improved, specifically looking at limitation in mobility and limitations in pain. In conclusion, TAC is a new therapy for below-the-knee dissection repair. It's unique in the sense that this is the first trial that enrolled 100% of dissected vessels, and it successfully met all primary and secondary endpoints, and it had impressive results both for safety and efficacy as seen here. Additionally, the TAC system preserves future treatment options for reintervention, whether it be endovascular or surgical. I greatly appreciate you joining us here today to discuss the TAC system.